As part of the international research collaboration grant between the University of Aston, UK and the University of Newcastle, Australia, we have been working on the project entitled The Roadmaps to Manage Competition, Theory and Practice. We have gathered a team of renowned experts in the health economics field, which consists of Adrian Melia from the University of Newcastle, Australia, Francesco Paolucci from the University of Newcastle and the University of Bologna, Italy, Wynand van de Ven from Erasmus University, and John Armstrong from Allianz Global and the Health Insurance Authority, Ireland. And finally, myself, Josefa Henriquez from the University of Newcastle, Australia. As the title of the project suggests, we are exploring how health systems could move towards the managed competition model by elaborating first a theoretical component that consists of a conceptual framework and country case study comparisons, and second, a practical aspect where in country papers the framework is applied. Some of the countries considered include Australia, Ireland, Chile, and the UK. The final aim is the publication of this collection on a journal as a special issue. The background of the project is situated in how health systems, insurance, and financing can be organized. One way is through a mixture of public-private involvement, as in Australia, Chile, and Ireland. Such organization creates two-tier health systems, as by construction, it allows consumers to have preferential access to the basic standard of care, like skipping waiting times. The degree to which efficiency and equity are achieved in these types of systems is questioned. To solve the problems arising with two-tier systems, countries may want to integrate the health systems by going NHS, like in the UK, Italy, or Spain, or social health insurance, like in the Germany or Netherlands. In this paper, we explore integration by means of a managed competition model, which underpins social health insurance. What is the managed competition model? The theory of the model outlines tools to exploit market concepts such as competition and choice to achieve efficiency while dealing with equity concerns, like access and cream skimming. This is not the first time the idea of introducing this model in the countries has been explored. In Australia, the National Health and Hospital Reform Commission in 2009 in the so-called Medicare Select proposal. In Ireland, this has been outlined in the Programme for Government as Universal Health Insurance the Dutch Way. In Chile, for example, it has also been outlined in the Programme for Government as a Universal Basic Package. In several other nations, which managed competition prevails, are elements of it in their health system. Why? For the desire of increasing efficiency in their systems and to address perverse incentives in the provider sector. Given the provided background, what we do is elaborate a two-part conceptual framework that describes the requisites for managed competition and the possible ways to achieve that model. We revise the original framework of preconditions by Van de Ven by complementing the existing and adding new preconditions to be able to cover a broader range of health system settings. We typologize and comprehensively describe roadmaps for health systems to achieve the managed competition model in three areas: insurance and financing, provision, and governance and regulation, which previously lacked a consistent approach. Our first result is the revision of the preconditions, as these had already been outlined in the literature and consist of 10 preconditions or requisites necessary to have in place so that the model is fully achieved, which include from free consumer choice of insurer to guaranteed access to basic care. We added new preconditions, like the necessity of a basic benefit package, affordable out-of-pocket payments, no conflict of interest by the regulator, and some general non-health preconditions. In regards to the second part of our conceptual framework related to the ways in which the countries' two-tier systems could transition to the managed competition model, we have first typologized three arrangements closely related to the way in which the insurance function is organized and consist of the convergence of the public and private scheme, with a relevant stepping stone being allowing choice through opting out of the public scheme and going private. Then abolishing the private sector and establishing the principles of managed competition within the public system as a second option. And finally, abolishing the public sector and establishing the principle of managed competition within the private system. Related to those elements of the provision function, several characteristics that diverge from the managed competition model need to be modified, and we have outlined the following: contracting restrictions and mandatory financing of providers, provider payments and tariffs, human resource hiring and types of contracts, insufficient number of hospitals or providers and sparsity of the hospitals, different nature of providers, and governance of these providers. The final function was the governance and regulation, in which we came up with a series of points that need to be considered to achieve a good governance, including allocating all the governance tasks, establishing the task in the agency institution that knows best, avoiding the judge, jury, and executioner problem, and formulating clear goals and accountability mechanisms. Of the managed competition model and outline several roadmaps or possibilities for the countries to move to the managed competition. The focus on case study that differ from the managed competition initially has broadened the previous scope of the frameworks that were bounded to countries which have already social health insurance principles. Despite the focus of countries with a specific health system, the tools described in the managed competition model, their trade-offs, can be applied to many countries, including reassessing social health insurance systems and national health service systems, as we discussed how competition can occur in the public setting too. There is still work in progress, which is specifically related to the application of this framework. We have asked a series of contacts, which include our partners at the Aston University, to evaluate to what extent does the country meet the preconditions for equity and efficiency, with the aim of this exercise being determining how a country's health system would transition to a managed competition model by applying but not bounded to the conceptual framework, and based on the end models described, to assess to what extent the preconditions in the framework are fulfilled with respect to the current system by assessing the gaps. Thanks for listening.